Welcome everyone. Thank you very much for logging on this evening. My name is Jamie. I'm the Business Development Manager here at Kim's Hospital, and the gentleman you can see on your screens is Mr. Jamie Young, Consultant Orthopaedic Surgeon. We were going to allocate around 45 minutes to an hour for tonight's presentation. We've got quite a lot of pre-submitted questions that we're going to answer at the end. We do think that a lot of the questions are covered during Mr. Young's presentation, which we think could take probably about 20-30 minutes. As I say, we'll allocate some time to go through the pre-submitted questions towards the end. Please feel free to use the Q&A feature on the right-hand side of your screen. We've got a team of people at Kim's who's going to be monitoring that, and we will also go through any questions that you think of during the talk towards the end of the presentation. If you do feel that your question either isn't covered, isn't answered, or you'd like any further points, please feel free to contact marketing@kims.org.uk. We're very happy to liaise with you individually and follow up with you if you would like any further information. And it's just to let everyone know that a recording of tonight's event will be sent out directly to you using the email address that you signed up with in the next few days. So without any further ado, Mr. Young, we'll hand over.
Well, many thanks, Jamie, and welcome to everyone joining us tonight. It's a pleasure to be here and talk to you about knee pain and what your options are. My name's James Young and I'm a consultant knee surgeon here at Kim's Hospital. So the plan tonight is to give you a bit of a background about me, about knee pain, arthritis, symptoms, non-surgical options, and then moving on to surgery. And obviously we'll cover questions in more detail at the end. There should be a good amount of time to discuss any questions that you may have. So that's me, or it was a few years ago. I'm a London-trained orthopaedic surgeon. I trained at St George's in Tooting and the southwest part of the Thames training programme. I went to Australia for my fellowships in 2014. Can't quite believe it's nearly 10 years ago. And I trained in Australia in knee replacement, but also in robotic knee surgery. And I'm a consultant knee surgeon in the area. Maidstone and Tunbridge Wells hospitals is where I work in the NHS, and I also work at the Nuffield in Tunbridge Wells and here at Kim's Hospital in Bearsted. So my interests are everything knee. So that goes all the way from younger patients with soft tissue sports knee injuries that need ligament or meniscus repair, cartilage regrowth, and then into knee replacement territory and other operations for knee arthritis. What we're going to talk about today is not the soft tissue side of things, but actually knee replacements and possibly some other surgical or non-surgical options. So it's important just to realise that there's often been a precursor to developing arthritis. The reason we get arthritis is that there's been damage to the knee, to the cartilage layers, and often the meniscus, and that may have been a previous sporting injury, it may have been previous surgery, it may just be what we term wear and tear. But as we get older, our body is not as good at regenerating and repairing itself, and that's why these problems can become more of an issue in our older years. So the sort of symptoms we're talking about are usually a gradual onset of an aching, gnawing pain, often worse with activity, often worse at night time, may lead to a deformity in the knee, and that's often shown on x-rays by narrowing of one or other side of the joint. And stiffness is also commonly reported, usually in the morning when you wake up and after periods of rest, long car journeys, sitting in a theatre or on a bus, those sort of instances. And it's really common to get arthritis. Osteoarthritis is the wear-related arthritis that we're talking about. For most people, 5 million people in the UK now suffering with arthritis, and 20% of us over the age of 45, and 30 or even more than 30% of patients over 75 have arthritis. And these are really statistics now that are 6 or 7 years old. Back in 2000, the knee replacement was the gold standard for knee arthritis. So 25 years ago, this is what everyone really was being offered. There weren't many other options. And as a result of that, and probably as a result of that, there were multiple papers in around the 2010 to 2014 timescale, reporting poor outcomes and satisfaction rates of only about 80%, meaning 20% of patients were really not happy with their knee replacement. And things have changed, but I think because we have more options, we're able to delay knee replacement, and also we have a better technology now, better ways of putting knee replacements in, and a better understanding of how to do these operations. So there's always options in life, and the options for knee pain that is arthritis related, well, one of them is to do nothing. You can carry on with knee arthritis. It is very much down to symptoms and how much it affects your life as to whether or not you want to have anything done. The only thing to really be clear on is that if you let arthritis get too severe and you let a deformity, for example, get too severe, then a simple form of knee replacement may no longer be an option. But there are plenty of people who are managing very well with arthritis and don't necessarily need to have surgery. The second option is to be proactive and do everything other than an operation, what we call a conservative or a maximal conservative approach. And we're going to go through all of that on the following slides. And then, of course, we've got the option of an operation, which is really the last stage, or should be considered the last stage in these options. So firstly, conservative measures. What can you do just to manage pain initially when it's just there, usually at a relatively low level, but not affecting your life too much? Well, you've got pain relief, you've got paracetamol. There's obviously a simple painkiller. Non-steroidal anti-inflammatories can be used. Not everyone is happy taking non-steroidals, and they don't suit everybody. There are stronger medications such as Zapain, which has some codeine as well. So there is a sort of analgesic ladder there, and a lot of patients will take painkillers, but usually get to a point where you've just felt we're taking painkillers every day, all of the time, and so it doesn't suit everyone. But what it can do is it can buy you a window of opportunity to lose some weight, to have some physiotherapy, and to start a strength and exercise program, which are all well known for improving muscle control, range of movement, and suppleness of an arthritic joint, and actually improving some of your pain. Weight loss, you should be aiming for a BMI of under 30, which is not always easy to achieve for any of us, but that does make a difference to your life, to your general medical condition, and to the amount of load that goes through the arthritic part of your knee. And then there are things like home adaptations and walking aids. There are braces that you can try. Some braces really are just sort of supportive sleeves, which can improve symptoms to a degree. There are braces when you have arthritis only on one side of the joint. These are called offloading braces, and you can see an image of an offloading brace at the bottom there. And these do allow people to get back to a decent level of activity before considering surgery, for example. And then we're on to other things like injections. So there are all sorts of injections available now that weren't necessarily available previously. Steroids have been around a long time. Steroids are good for short-term symptomatic improvements. They are anti-inflammatory, and I tend to use those in my practice for patients who just want to get over get to their daughter's wedding or have that nice holiday that they've been promising themselves for a number of years. We don't like patients to have too many steroid injections because it can soften the decent cartilage that's still in the knee. And also there's what we call a deleterious effect with steroids. So they tend to be quite, well, for most patients, they are successful to start with, but after the second or third injection, that effect tends to be less good and shorter lived. There are other injectables such as hyaluronic acid. That is essentially a lubricant that goes into the joint, and there's an image of that. The top image is something called Cingal, which is a hyaluronic acid with a small dose of steroid as well. And patients can get up to a year or even slightly longer of symptomatic improvement, about 70% of the time. So it doesn't work for everybody, but these can be useful for the sort of 12-month time frame. PRP is platelet-derived repair factors. Again, data does show that it improves pain and function, but the long-term data is still being collected, and that's the same for lipogems. These are stem cells, and the same for the newer hydrogels that have been used for years and years by vets. And actually there's 20 or so year data from the veterinary side of medicine showing good function in horses, but we don't have anything more than 2 or 3 data on some of those injections. It is impressive though. Some of that data is showing 70 or 80% response after 3 years for some of those hydrogels, such as arthrosamid. With surgery, if it isn't worn, then leave alone. So some patients, such as the image that you see bottom left, where there's a black arrow pointing to the arthritis, you can see that that side of the joint is completely narrowed. There's no gap there anymore, and that gap represents the cartilage layers in the knee. And when you're down to bone-on-bone arthritis, but only in one part of the joint, then why would you want a full knee replacement? It doesn't make sense unless you have widespread pain or arthritis. So for that type of knee arthritis, my preference would be a partial knee replacement, and that's the image shown there with just the half knee being replaced. The benefits of that are it's a faster operation, it's a faster recovery. You're in hospital for a shorter period of time. Half of these cases are now done as day cases. It gives you a better functional outcome and a knee that feels more like a normal knee because you've kept all of your own ligaments. You don't lose your cruciate, your all-important cruciate ligaments in the center of your knee. They are protected with a partial knee replacement. If you have wear, though, that is more generalized in your knee, or you have a more significant deformity, such as the larger x-rays that you can see there, then you're looking at a full knee replacement. A good pain-relieving operation and good functional outcomes being reported now compared to back in 2000. So surgery these days, with proper counselling, more than 90% of patients are satisfied, and the 20-year survival rate of these implants is now over 90%. Okay, so we seem to have cracked it on a number of levels. I'm not saying it's perfect, but it's certainly much, much better than it used to be. And when I'm sitting down with patients who are in their 70s and we're talking about knee replacement, I can tell them that there's a 90% chance that this knee replacement is going to last them into their 90s. I think it's important to pick your surgeon. Like with anything in life, you want someone that does lots of knee replacements, high volumes, and you want to be using implants with excellent data. We've had the National Joint Registry, the NJR, in the UK for many years now, and we know that there are very, very well-performing knee replacements with very good long-term data. So it's important when you talk to your surgeon that you know what implant they're going to use. And ODEP is something that we use, also available in the public domain, to look at how well implants last and what the data is behind those implants. So ODEP will look at both the longer-term evidence behind an implant and how long that evidence is. So the number is how long that evidence has been around. So you really want evidence that's been around for at least a 10-year period, and the strong evidence, which is the A and the A star. And here at KIMS Hospital, the partial knee replacement that we use is called the ZUK, which is a 10A rated implant, and the Stryker Triathlon, which is a 10A star rated implant. So those are as good as you can get. In fact, the ZUK is the market leader in terms of longevity. And then there's different ways of putting implants in. In the old days, and in fact, even today, I was using conventional jigs for knee replacements. And these are a very good, tried and tested way of putting a knee replacement in. But it's not particularly customized to a particular patient, and it doesn't give you necessarily perfect balance through an entire range of movement. And this is where robotics comes in. So robotics is using the same implants, but with new technology to actually place the implant in the perfect position. It's still controlled by the surgeon, but it's a robotic arm, as you can see in this photograph. And it does allow us to improve our implant positioning, to customize to some extent to your own anatomy, and to balance the ligaments, the soft tissues, the control movement, to balance those perfectly throughout a full range. Now, we don't have long-term data on robots, but what we do know is that it certainly puts the implant in a better position. It gives you optimal balance, and some papers have actually shown a faster recovery. But at the moment, we don't have the longer-term data to say that it gives patients a better functional outcome. But having said that, with all of the other pros there, I know which one I would prefer to have if I had the choice. So how it works is you have x-rays as usual in clinic. You'll then have a CT scan, and that will make an accurate 3D model of your own knee. And that will then allow us to do a preoperative plan by putting these mock implants in green over the surfaces and tailoring that to the shape and to the shape of your knee. When we're then in theatre, we can make tweaks to that plan based on the actual model that your knee that we have in front of you, and we can improve balancing further. It does add a few minutes to each case, but as I say, it gives you that tailored implant position.
Our knees are the largest joints in our bodies. They're central to almost everything we do. So if you or a loved one is suffering from arthritis or an injury to the knee, everyday activities such as walking, sitting, or kneeling can feel debilitating. One possible treatment option for knee pain is total knee replacement, a procedure that involves removing the damaged bone and cartilage, then replacing the knee joint with an implant to reduce pain and restore the motion and function of the knee. Meet Mako, a robotic arm-assisted technology used by surgeons to perform total knee replacements. This unique technology helps surgeons provide a personalized surgical experience, where each surgical plan is based on a patient-specific diagnosis and anatomy. And in a laboratory study, Mako Total Knee enabled surgeons to execute their plans more accurately, while also protecting soft tissue and ligaments from damage. Let's take a look at how it works. It begins with a CT scan of the knee joint. A CT scan is a series of X-rays taken at different angles that can help surgeons see things that they can't typically see with an X-ray alone. The CT scan data is used to generate a 3D virtual model of the patient's unique anatomy. This virtual model is loaded into the Mako system software and is used to create the personalized preoperative plan. Prior to surgery, the surgeon reviews the plan size and placement of the implant, and if necessary, modifies the preoperative plan in order to better position the implant to the patient's unique anatomy. During surgery, the surgeon locates points on the knee in order to register the anatomy in the Mako system. This process establishes the relationship between the patient's actual anatomy in the operating room and the 3D model that was used during the planning process. This step helps ensure the procedure is executed to plan. Once the anatomy is registered to the 3D model, the surgeon has the flexibility to modify the preoperative plan based on their assessment of the patient's anatomy and range of motion. Then, the surgeon guides the robotic arm to remove the arthritic bone and cartilage from the knee. A virtual boundary provides tactile resistance to prevent the surgeon from removing more than just the arthritic bone identified in the preoperative plan. And visual cues, shown in green, appear on screen to show how much bone to remove. Collectively, these cues help the surgeon stay on the preoperative surgical plan. With the diseased bone gone, a knee implant is inserted into the joint space. And once the surgeon is comfortable with the knee's movement, it's off to the recovery room to begin the journey towards strengthening the knee joint.
So that was the Mako robot. That's available here at Kim's Hospital, and that's the only Mako robot in Kent. After surgery, you go around to the recovery, and We have tailored anaesthetic and pain protocols to ensure that you have less sickness, a faster recovery and a faster discharge home. Physiotherapy, the physiotherapist will get you up the same day, and as I said earlier, for partial knee replacement, half of patients will actually go home as day cases on the day of surgery. It's a cryotherapy machine, and the bottom picture there, which is an excellent adjunct to patients recovering from knee surgery. It's a sleeve around the knee, and this machine that you can see in the foreground there, that pumps cold water around that sleeve to keep your knee nice and cool and to minimize swelling. So there were a few questions that I saw about recovery, and there was a lot more information about recovery and timelines to get back after knee replacement surgery on my website, invictaclinic.com. There is a section on rehabilitation and a section on knee replacement, which will give you some details. But in hospital, usually after a full knee replacement for 1 or 2 nights, off crutches usually by about 6 weeks, exercise bicycle around 4 weeks, road bicycle around 10 weeks, and back to golf at around 4 months. It is faster, all of those timelines are slightly faster for partial knee replacement, about 50% faster. So in summary, there are 3 options available. The surgical techniques are evolving. We have new technology. Things are more precise than they used to be, and outcomes are improving. I've just got a video here of a patient of mine who is 6 months after his knee replacement. And I'm not saying everyone will be back to skiing at 6 months, but it's not unheard of at all.
Good afternoon, Mr. Young. My first day back on skis since my knee replacement. Thank you very much. Just wanted to say best wishes, and yeah, thank you for getting me back on my skis.
So that's my little bit done. I'm sure there are lots of burning questions. This is probably the most useful part now, that we can actually clear up any concerns that you might have, demystify things, allay any concerns, and answer your burning questions. So over to you.
Thank you, Jamie. That was really informative. So just for our attendees, as we said at the beginning, I think we've asked you to submit some of your questions that you might have around knee conditions or knee replacement. We've got quite a long list of pre-submitted ones. We're going to skim over some of them because we feel that the presentation Mr. Young has just completed, it covers quite a lot. However, we will run through them. If there are any, as I said at the beginning, that you feel aren't answered correctly or you'd like a bit more information on, we're very happy to follow up with you after the event individually, provide a bit more detail and context. So, Jamie, number 1, what are the risks of delaying surgery?
So I think with anyone thinking about surgery, and if you got to the point where everything else has failed, I think you need to try everything else first. And I think if everything else has failed, then the risk of delaying it is that your muscles will probably get weaker, your joint may become more stiff, and as I said, with worsening deformity and worsening arthritis, the surgery just does become more difficult and more complicated. Also, the best predictor of your post-operative range of movement is actually your pre-operative range of movement. So it's better to have the surgery if you're considering that, and if your pain is significantly bad on 4 days of the week or waking you up regularly at night, before your knee gets really stiff. And I will often get patients to see physiotherapists before surgery to try and get some suppleness back into that joint, with the above in mind.
Number 2. So this is broken down into a few different parts. So we'll go through it individually. Talking about anaesthetic, is an epidural anaesthetic used to conduct knee replacement?
It is. Yeah, it's usually an epidural. Sometimes for the partial knee replacements, when you're going home the same day, it's a short-acting general anaesthetic. But for most patients, it'll be an epidural. That is the safest form of anaesthetic, and it's incredibly safe these days. And there's more chance of having an issue coming into hospital driving into hospital than there is of having an issue with an epidural anaesthetic. So that is the safest way of doing it. I think the next part of the question was how long a stay. I think I covered that. It's usually a couple of nights, can be shorter. The average length of stay here at KIMS for a total knee replacement is 1.8 days. And expected recovery time, I did cover that. I mean, it isn't a walk in the park. The first few weeks are tough. You won't like me very much for a couple of weeks. When we see each other at 2 weeks after surgery, you may well just about look me in the eyes, but no more than that. And it does take a couple of months to be smiling and thinking that was all worthwhile. So it is a sore operation.
Number 3, going to sort of analgesics, pain management. What pain medication will a patient be on after surgery?
So it's usually paracetamol, either ibuprofen or naproxen. And if they irritate your tummy, we can give something to dampen down the stomach acid and help with that. And then usually an oral opiate as well. We don't tend to give you codeine if we can help it. We don't tend to give you tramadol. So there's a sort of triple whammy there: paracetamol and an anti-inflammatory regularly. Regular ice packs is obviously as pain relief as well, and then an opiate, which you can add in as necessary.
So we have covered this one, but when would you perform a partial knee replacement instead of a full replacement? And perhaps just elaborating, do you see any trends in the types of patients, i.e. younger patients, who may be opting for partial knee replacements?
So I would not replace a full knee with a patient that only had pain and arthritis in one part of the knee. I would try and talk them out of having a full knee, because the partial knee removes less of the joint, leaves more of the native joint there, it leaves the ligaments alone. It's a faster recovery, it's a better functional outcome. So we don't want to be throwing out the bathwater with the baby. If the rest of the knee is okay, then leave it alone. Younger patients, I mean, the young patients who get arthritis commonly have had surgery or an injury previously, and so it does tend to be only in one area of the knee. So because of that, a lot of them are looking at a partial knee replacement. There is something else called an osteotomy that I also another type of operation I do for younger patients, where we can realign the leg, but it's one or other of those options rather than a full knee replacement. Yeah, if you have a partial knee replacement and you're in your late 40s or early 50s and you wear that out, we can do it again. We can revise it, or we can do a full knee replacement later down the line. Because someone's in their 70s or 80s, I wouldn't say, well, you've got to have a full knee replacement, but the same rules apply.
In the event that both needs require an operation, can total knee replacements or partial knee replacements be conducted at the same time?
They can be, and in Australia we did that regularly. It really should be reserved though for very fit and healthy younger patients, because it's a big hit. And we know that the morbidity and mortality is slightly higher by doing both operations at the same time. So your rate of getting a blood clot, and they're a little bit higher. So I would try and talk patients into having them a few months apart if at all possible. 3 months is usually the time frame.
What are some factors which determine the success of a total knee replacement?
So you've got the preoperative factors. So that's the physio, the rehab, getting your legs strong. Having an exercise bike is often a really good thing to do if you've got an arthritic knee, because it doesn't overload the knee. It's a nice cyclical movement. So exercise bike, cross trainer, rowing machine are often well tolerated. So getting that preoperative strength, range of movements, getting that knee control as good as you can before surgery, really important. Choosing the right, good surgeon to do it for you, someone with a track record, someone with a high volume, and then post-operatively you've got the analgesia to allow you to get that range of movement up, the ice therapy, the early rehab. All of those are really important factors.
We did touch on PRP in the presentation. One of our attendees has asked if it's an alternative to total knee replacement.
I think the data is sort of building. I would worry about relying on, so what the way PRP works, and the sort of lipogems as well, is it's introducing growth factors into the joint to try and stimulate repair. So if you've got end stage bone on bone arthritis and the whole joint is worn out, or the whole of one side of the joint is worn out, you're asking an awful lot of a blood injection with some growth factors in it to recoat the whole thing with cartilage. It just, there's no evidence in the really advanced arthritis that works. So I think the indications for all of those injections are slightly different to the indications for knee replacement, which is for a more, the knee replacements are for more advanced disease, certainly in my practice.
Talking about Mako now, what are the advantages of robotic assisted surgery? Are there any drawbacks or risks? Are the outcomes significantly better? And finally, do you have any views about Conformis custom-made knee joints as an alternative option to robotic assisted arthroplasty?
So the point in robots is to take implants that we know have a good and long track record. So that's the ODEP 10A implants that we talked about. We know they do well, and there's very good data to back that up, and put them in an optimal, precise position, tailor-made for each patient. It is almost impossible to mimic that every time using humans and conventional jigs. There is always going to be a little bit of an outlying area where there's a little bit of imbalance, and it's not quite as perfect as maybe you would like it to be. So it's really all about positioning for the robot, and there's no doubt that whenever robots have been introduced into anything, they do tend to be slightly better than humans because of the lack of human error. So that's the main benefit to robotics. Are there any drawbacks? Not really. It's a slightly longer operation. It's a few minutes longer, maybe 15 minutes longer. In a 45-minute operation, you may be looking at a 1-hour operation. So if you're using a tourniquet, that tourniquet time would be a bit longer in terms of blood loss, in terms of wound healing issues, in terms of time in hospital, in terms of recovery. There is no appreciable difference. Do we know about the outcomes? We haven't shown yet that robotic placement of knee replacements gives you better functional outcome. But what we do know is that computer assisted surgery, which was the prequel to robots, so this has been, computer assisted surgery has been going on for 30 years in Australia and other places. The Australians were really big, really took this up in a big way, and they've shown that the computer assisted knee replacements do have better outcomes. And that they've got 30-year data obviously on that. So we think that robots which are based on computer assisted, but the sort of next thing, will ultimately show that it's better. But that data is not yet there. Conformis, custom designed implant is what a conformis is, if anyone's unsure. So that's where a CT scan's taken of your knee, and instead of having an off-the-shelf implant, you have one that is designed exactly for your knee. There is no data at all to show that Conformis is better than standard knee replacement that I'm aware of. And having seen that question, I did Google it and I did look at all the papers on this. There just isn't the data to show that there's a significant difference. So I'm not sold on that. It's also not got 10-year data.
Question number 13. What's your availability like? So when are you at KIMS? Frequency of clinics? When could one of our attendees potentially book in to see you?
I'm at KIMS Mondays and Fridays for clinics, and I operate on a Wednesday and a Friday. And at the moment, we're looking at about 3 to 4 weeks for a clinic appointment, around 3 weeks for clinic and around 4 or 5 weeks for surgery.
What's the cost of having a total knee replacement carried out at KIMS, and what's included in the price?
That's a question for you, isn't it?
The manual technique, the traditional technique, is just slightly over £11,000. The Mako robot, as we've discussed, it does take longer in theatres. There's some pre-operative diagnostics that are carried out so the Mako can function properly. So there's a slightly uplifted self-funding fee depending on the consultant that you choose, but the guide price that we give is £13,500. So it's a slightly uplifted fee to accommodate some of the extra costs. Going on to question 15, can elderly people have surgery at age 77? And if you could comment on the recovery time if sedentary active.
Yeah, I mean, 77 really not that old. So I don't, I think my oldest knee replacement's in their 90s. So it comes down to your activity level, and there's some very active people in their 70s, 80s and 90s now. So obviously medical fitness is important, and that will be assessed at pre-operative assessment. Recovery time, the recovery times I've given you are based on patients who are in their 70s. Most of my patients are in that sort of age range.
Does the risk of complications in elderly patients, is there any correlation?
I suppose the honest answer is yes. I mean, if you are a more frail person with lots of other medical problems, your risks of having an issue are slightly higher. But we certainly wouldn't get you into a position of coming in for surgery if we thought you were very high risk. We would have all of those discussions far sooner than that, and that would be assessed in pre-operative assessment. Sometimes things are picked up in pre-operative assessment and patients will go back to their GPs, or we can refer on to one of the medical consultants, and those issues can be sorted out, and then they have surgery a few months later.
This is from one of our attendees. I've had numerous arthroscopies in the past. My knees are painful under stress or at angles. How do I know when the time has come to seek further treatment? I was told many years ago that it was only a matter of time before replacement surgery would be required. I've avoided seeking advice all the time I can manage the pain, as I really don't want to take the risk of making things any worse. I'm 63 years old, enjoyed a sporting life, and still enjoy golf and skiing.
So, I mean, it's a lifestyle decision, really, when to have knee replacement surgery. And I think you've got to weigh up the risks and the benefits. And for most people, the benefits outweigh the risks. Once your everyday life is affected at least 3 or 4 days of the week, or your sleep is affected 3 or 4 days of the week, if more than half of your life is now really getting you down, that's usually the tipping point at which knee replacement becomes a good option. So that would be my advice. But if you're an active person, you want to get back to playing golf and doing some skiing, and you can't, then for some people that's a big deal. And I would hope you could get back to those pursuits after knee replacement surgery.
So moving on to slightly different intervention at the moment. I've recently had a meniscus repair, and it's still incredibly painful with prior movement.
And I think it was 6 weeks, wasn't it? 6 weeks down the line for a meniscus repair. I mean, that could be so many things. That's a difficult one to answer. Meniscal repairs can be sore and stiff for a couple of months, but by 8 weeks, 10 weeks after meniscus repair, you really should have full range of movement back. You should be fully weight bearing. So, I mean, I would probably be, if you're sort of 6-8 weeks and the knee is still miserable, then I think it's probably time to go and see the surgeon again, or somebody else if you're not sure about the surgeon. But that would be, I would be expecting you at 8 weeks to be starting to rally.
Thank you. So I'm 51. I have no cartilage left in my knee. I've been an ultra marathon runner for the last 20 years, but can't run any further. My knee is painful all the time. My dad had the same issue, but was not a runner. So I believe this could be a hereditary condition. Will knee surgery work for me?
So it'd be really nice to know where in your knee the wear is. If it's all on one side of your knee joint at your age and with your wanting to get back to be a runner, osteotomy might be a better option for you, so changing the alignment to put all of the weight through a better part of the knee. If it's both sides of the knee that are worn out, then certainly knee replacement would be a good pain reliever. But you're young, and you need to know that at the age of under 55, the results of knee replacement are not as good, because you're younger, fitter, healthier, and we know from the National Joint Registry that patients get a worse outcome if they're under 55 when they have a full knee replacement. I'm talking about full knee replacements there, but I think if you had a full knee replacement, so your running days would be over. I don't think you wouldn't be able to get back to doing ultra marathons after that.
Would that be the same for most people undergoing knee replacement? Running is going to be tricky in maybe prior capacity after that operation?
Yeah, I mean, it's just, the thing is, it's younger patients. You've got an implant that's cemented in, and we know that if you're hard on a knee replacement, you're going to wear it out a bit quicker. So it's just, running is hard on knees, and so you'd be much better off swimming, cycling. And I've got patients who've gone back to playing a level of sport, a level of tennis, a level of hockey, but it's hard on knees, and it's not the ideal. You wouldn't do a knee replacement and say, I'm doing this so you can run. That's not the point. The point really is to get you out of pain, and get you back to a level of activity, but probably not as dynamic as some people would like. And so that's just about the counselling, and just making sure expectations are not too high.
What is the important precaution for a physiotherapist in dealing with early post-operative patients with knee replacements?
Precaution-wise, I mean, the problem is that patients are sore, and the first few weeks are really hard. You've got to let the swelling settle to some degree. You've got to let the pain, you've got to make sure the pain's controlled. So I think the first couple of weeks for physios are difficult, because there's not an awful lot you can do. We're going for gentle improvements in range of movement. You're going to definitely try and get the patellar mobility improved, because that's all important for getting range of movement ultimately. But the first few weeks are tough. Life gets easier after about 4 weeks, but you've got only really got 10 to 12 weeks to get that initial range of movement as good as you can, because once the scar tissue sets in, it can be harder to achieve. But the first few weeks are hard.
Does reiterate the importance of really committing post-operatively to physiotherapy and getting on with it as soon as possible.
Yeah.
How is a long-term IT band issue likely to impact on the knee? Could it be the cause of knee pain?
Yes, IT bands can cause knee pain, usually on the outside, as you know. If you're listening to this, whoever asked that question, but this is rarely needs surgery. It's usually non-operative management, resting, icing, anti-inflammatory, stretching. The sports medicine team here are very good at managing IT band issues. So Stephen Thompson in the sports medicine team at Kim's Hospital would be useful, I think, to go and see with those sort of problems.
This is a bit more specific to a particular exercise. So would I still be able to partake in my yoga and Pilates classes, and would there be any restrictions, i.e. kneeling?
Yeah, no, absolutely. I mean, getting back to yoga and Pilates, brilliant for knee range of movement and ultimately in recovery. You're not going to do it in the first few weeks, but that certainly should be something you aim for. Knee replacements, if you look at the data, only half of patients actually like kneeling on their knee replacement. Half of patients do not like the sensation of kneeling on it. Now, there's nothing wrong with trying to kneel on a knee replacement. You're not going to make it loose. It's not going to have issues from a surgeon's point of view, but it's certainly just worth considering that 50% of patients don't like kneeling afterwards.
So we've spoken about golf, we've spoken about skiing, spoken about running. This patient is 58, he's a surfer, been suffering for nearly 40 years, needs a total knee replacement. Will I be able to continue surfing after recovering?
Certainly worth aiming for. No reason why you shouldn't get back to, if you can ski, it's not and snowboard, and I've got patients who do both of those things, I can't see a reason why you wouldn't be able to get back to surfing. It's going to be all about the recovery and the rehab. And so it's all about getting the range of movement before, making sure that your muscles and everything are in good condition, getting that good range of movement before surgery, and then working hard afterwards. And there's no doubt that knee replacements, they do well. We've got good satisfaction rates now, but it's hard work. So you do have to be in it for the long haul.
So is it possible to preserve the ACL and PCL in a total knee replacement?
It is. There are implants now that do preserve both ACL and PCL. We don't use those at Kim's Hospital though. But yes, the answer is that there are knee replacements. There are loads of different types of knee replacement. There are some that move in a slightly different way called medial pivot knees, and there are some that hold on to both the ACL and the PCL. And so yes, that is possible.
Number two, so this patient actually has a date booked already for surgery. We have spoken about running, but we'd just like some context or some reiteration around how soon it's probably feasible to plan jogging post-operatively again.
I think jogging, honestly, I think jogging is one of those things that, personally, I would be very I would be careful with promising you that you're going to go back to running. It's possible. It's possible, but it's probably the last thing that comes in because it's such a dynamic sport. So the first things that come in are getting the endurance back, getting your leg muscles back, and the use of an exercise bike, cross trainer, rowing machine, swimming. Those sort of more gentle exercises that don't overload the joint in one particular position would be the thing to aim for first. I mean, light jogging is possible, of course, and you'd probably be looking at around 2 to 3 months, probably nearer 3 months for that. It's not. I don't think you can promise everyone that they're going to get back to running.
Sure.
Maybe on a treadmill, but I think difficult to promise that out on the roads.
Okay. Moving on to Makers, does robotic surgery reduce the scar size?
No, it does not, I'm afraid. The scars, if anything, you end up with another scar below the large scar over the front of the knee. There's a scar below that because you have to be able to put in special trackers, and those trackers are picked up by a camera in the room so that the robot can work out exactly where the knee anatomy is, and they do need to go into a different areas. The scar's not smaller, no.
My knee issues began 42 years ago with an operation to remove my cartilage. It turns out it wasn't fully removed, just the damaged part. Since then, I've lost count of the number of arthroscopies on one knee, then a detached cartilage on the other knee. Pain in the knee is not constant, but it is in cold weather or when under pressure, i.e. walking, golf, skiing. When skiing, I use a TENS machine and Voltarol to help manage the pain. Would you suggest the injections mentioned would do a better job to manage pain?
I mean, very possibly. It would be worth having an up-to-date scan to see exactly what the cartilage layers look like. But very possibly for you, injections might be the way to go, because it doesn't sound like your knee is massively affecting your life all of the time, and it's more sort of activity related. So yeah, that may well be good for you.
Do you use robotics for every knee replacement at Kim's, or is it optional or only for some? So I can answer this one. This is dependent on preference between the patient if they're interested in robotic surgery. Obviously, the appropriate consultant would discuss if it's feasible for them, if it's suitable. But there is definitely an option for patients. It's all about making a collaborative treatment plan with the surgeon, agreeing on the type of intervention that's best suited for you. Any further elaboration on that, Jamie?
No, I think that's totally right.
What would you suggest if I have arthritis in both knees? How long would I wait between surgeries if they both need replacing?
I would wait a minimum of 3 months. Because what you don't want, so often when you have arthritis in both knees, you've been overloading one a little bit more than the other. You have a knee replacement, and that knee just needs some time for you to start putting weight through that leg so that you've got a good leg and then you have the other knee replaced, because you will want to be putting a lot of load through the worse, through the one that's recently been replaced when you have the second knee replacement done. So I do think it takes a good 3 months, but that's what I would be recommending.
I think this is our final question for the evening. What aftercare is included in the total price, and is a partial replacement cheaper? So just to also comment on this as well, aftercare, I think roughly 6 sessions of physio is pretty standard for a knee replacement. All post-operative care is covered under our self-pay guarantee here at KIMS. So if you needed, for instance, more than 6 sessions of physio, if it was clinically necessary, then it's covered. It's the same with staying at the hospital. If it was deemed clinically necessary that you needed to stay longer for, say, the average of 2 nights, this is all covered. Everything that you pay for pre-operatively, the package, if you deviate from the package, if you need more of something and it's clinically appropriate, then that is all covered within our self-pay guarantee at KIMS. I can say that there is a difference in price with a partial knee replacement. This is slightly cheaper. I would point you towards the website where the guide prices should be fairly transparent. You should be able to read a bit more about both procedures.
See, there is a new question that's just popped up. Do all consultants use the robots at KIMS? And I think the answer to that is no. Jamie, do you know the numbers?
Yes, so we currently have 5 consultants that are able to offer Mako robotic arm knee replacement. And Jamie, I understand you're going to be able to offer this to all patients very shortly. I know you've already done the training in Australia and you're going to be doing the Refresher UK module with Stryker very shortly, is that correct?
So I'll be using it from April, yeah.
So I think to answer that question, no, not all consultants are able to offer this. If you do look on the website, we do have a treatment page dedicated for Mako knee arthroplasty, which will give you some more information of the consultants that are able to offer that. I just wanted to thank everyone for logging on and listening. I believe that's all the questions that have come in. If you have any questions further that you would like to be answered or elaborated on, you're very welcome to email marketing@kims.org.uk, which is where the recording of this event will come from, the email address. And thank you very much. Thanks for everyone for joining us, and thank you, Jamie, for presenting.
No problem. Good evening, everyone. Thank you.
Thank you.